Welcome to the Optum Rx Pharmacy Insights podcast. In this forum, we'll discuss the latest and most impactful events in pharmacy benefit management. In this episode, we'll dive headfirst into the turbulent waters of the PBM regulatory landscape. Today, I'm joined by Marissa Schlafer, Vice President of Policy for Optum, and Sarah Strothman, Vice President of Policy for Optum Rx. Welcome, Marissa and Sarah. Can each of you give us a quick rundown of your background and what your responsibilities are at Optum Rx? Marissa, let's start with you.
Thanks, Scott. As you mentioned, I serve as Vice President of Policy for the Optum businesses, with the majority of my time focused on Optum Rx, which, as you know, includes both the pharmacy benefit management and pharmacy care services part of the business. My first responsibility is working with Optum business leaders like you to establish the company's position on current public policy issues, and then determining how to best advance those policy positions on behalf of Optum and for our clients. The other part of my role is helping business leaders and clients understand how federal and state policymaker activity will impact them. By background, I'm a pharmacist that has practiced in both managed care and community pharmacy settings. I've worked in the public policy world since legislation established the Medicare Part D drug benefit way back in 2003.
Great. Thank you, Marissa. Really appreciate you joining us today. Sarah, can you tell us a little bit about yourself?
Sure. Thanks, Scott. As Vice President of Policy at Optum Rx, I partner with our business leaders to develop positioning on pharmacy benefit and drug pricing policies. A big part of my day-to-day job is gathering and sharing information on proposed federal and state legislation that would be impactful to PBMs and PBM clients, and working with our advocacy colleagues on strategies to influence policymakers who are developing those laws. Although my current role does not involve rendering legal advice, by way of background, I am a licensed attorney and previously have held several legal roles at United Health Group.
Great. Thank you, Sarah. Marissa, I want to begin with you. Policymakers today are really focused on the PBM business model. Really from your perspective, what's behind the increased interest in regulating PBMs?
So the PBM regulatory landscape, just as you said, continues to evolve rapidly, both at the federal and the state levels. There's just so much pressure on members of Congress, state legislators, and administration leaders, both federal and state, to deliver on their promises to lower the cost of drugs. And policymakers are constantly being fed a narrative that PBMs are the problem, that PBMs are somehow responsible for the high and ever increasing drug prices, when in fact we know it's pharmaceutical manufacturers that set list prices for the drugs that they develop and bring to market. What PBMs do is offer tools to help employers, unions, government plans, other payers manage the costs of providing pharmacy benefits. PBMs are the only player in the pharmaceutical supply chain focused on lowering the cost of drugs and of prescription drug benefits. But the pharmacy supply chain is complicated. And while legislators have stated goals that are admirable, because the supply chain is so complex, legislation can have unintended consequences or even have the opposite effect of what is intended.
Sarah, it really sounds like to me that there is, overlap with some of the stated goals of federal and state policymakers, and really the guiding principles of Optum Rx, which really include, increased competition, lower drug prices for plan sponsors, and a better member experience. Can you talk about the intersection of those two?
Yeah, certainly I can. Let's take transparency as an example. Federal and state legislatures are focused on PBM transparency measures based on a belief that increasing PBM reporting requirements will translate to lower drug costs. Optum Rx believes in meaningful transparency for payers, prescribers, and consumers. Payers should have visibility to all of the information they need to make decisions about designing their benefits and managing their costs. Prescribers should know how much a drug they prescribe costs, what utilization management requirements may apply to the drug, and whether there are lower cost alternatives. And lastly, consumers need to know where the drug is available and what they will need to pay for it. However, too often transparency mandates are not tailored in a way to protect confidential and proprietary information. Rather, many of these laws require costly reporting of excessive information to government agencies without any explanation of how that information will be used. Expansive transparency mandates pose serious concerns that the information, if it doesn't remain confidential, will upend the competitive landscape that exists today in arm's length negotiations between PBMs and pharmaceutical manufacturers, as well as PBMs and retail pharmacy chains, PSAOs, or independent pharmacies, which will ultimately result in higher, not lower, pharmacy benefit costs.
Our industry is regulated at both the federal and state levels. Marissa, can we start at the federal level? Recently, we had the implementation of the IRA, the Inflation Reduction Act, and some very consequential judicial decisions. What are the big, impactful events of the past year, and what do you anticipate mattering most for plan sponsors as we head into 2025?
Yes, Scott, you're right. The Inflation Reduction Act, the components which have different effective dates, make several changes to the Medicare and Medicaid programs. So already in effect, we have the insulin cost sharing limits for Medicare Part D, and we also have some penalties for pharmaceutical manufacturers if Medicare Part B and or Part D prices increase faster than the inflation rate. Beginning in January 2025, we have the new $2,000 out-of-pocket spending cap for Medicare beneficiaries, and we have an option for beneficiaries to pay out-of-pocket prescription drug costs spread across monthly installment payments. And then January 2026, the first government negotiated drug prices for select Part D drugs go into effect, with negotiations on Part B drugs and additional Part D drugs rolling out in future years. These are prices negotiated by CMS, built on top of or built upon the negotiated rates obtained by Part D plan sponsors and their PBMs in previous years. So since the time of the enactment of the Inflation Reduction Act, or IRA, toward the end of 2022, Congress has continued to focus its attention on healthcare costs, specifically high drug prices. But after the Inflation Reduction Act, their focus shifted from pharmaceutical manufacturers to pharmacy benefit managers. So since then, over the last 18 months, congressional committees in both the House and in the Senate have taken on legislation aimed at prohibiting certain pharmacy benefit management tools and contracting methods. Congress has been referring to this legislation as PBM reform legislation, but I think it's really important for everyone to recognize that the legislation really would impact employers, unions, and other PBM clients, because it's really all about how payers manage their prescription drug costs. That is what is at stake with this legislation. Pharmacy benefit reform is one of the few policy areas where consensus exists across both Republicans and Democrats. The legislation has been considered by both parties, could impact both the Medicare and Medicaid programs, but this time around it could also impact commercial benefit plans, including self-funded plans. Congress has been expected to package various legislative provisions together and to advance them on some other moving legislation. So it may not pass as a specific piece of legislation focused on pharmacy benefits. So these could get attached to the legislation needed to fund the federal government for the next fiscal year. And some of these provisions that could find their way into the package include provisions that would dictate what reports and information payers receive from their PBMs, but could also impose a ban on one of the pricing methodologies that's used by many commercial payers. So a concern with this legislation that we have is that the federal government is taking away choice and flexibility for payers to use pharmacy benefit management tools in the way they want to decrease their costs in providing pharmacy benefits to their members. You also mentioned consequential judicial decisions. So I don't want to miss an opportunity to talk about a very important case that could affect plan sponsors' ability to structure their benefits in a way that works for them and in a way where they can have uniform benefits nationwide. Most self-funded plan sponsors rely on a federal law that is known as ERISA to manage their employee benefits. ERISA allows employers to manage consistent benefits across state lines without having to make modifications to comply with each state's unique insurance regulations. So the case we're talking about, PCMA versus Mulready, is a case that's on appeal to the United States Supreme Court. The issue is an Oklahoma law. It's already on the books and restricts a plan's flexibility in designing their pharmacy network. Specifically, it prevents plans from using preferred pharmacy networks, and it prohibits offering discounts to members who might use mail order and specialty pharmacies. So in this particular case, PCMA is representing prescription benefit management companies and is also acting to safeguard how payers design their prescription benefits. Most recently, the ruling on this case came from the 10th Circuit Court of Appeals and was in favor of PCMA. The court found that Oklahoma law, the provisions govern a central matter of plan administration, and therefore it's preempted by the federal ERISA law. So now the Supreme Court has recently announced that it will decide in May of 2025 whether to hear the case after it gets input from the U.S. Solicitor General's views on this matter.
Sarah, similar question for you, but I'd really like to get the perspective, from the state's point of view. We know that there are literally hundreds of bills introduced each year in legislatures across the country. As you look across all this proposed legislation, are there certain overarching trends you've identified that people should be aware of?
Yeah, there are. State policies are very active in this area. For several consecutive years, we have seen the introduction of over 500 bills by state legislatures that would impact pharmacy benefits. And the overarching theme of this legislation is government entities dictating how PBM clients' pharmacy benefits should be managed. There are a range of different topics that fall under this overarching theme, and I can highlight three topics that are especially common: a ban on traditional or spread pricing arrangements, restrictions on how pharmacy networks are designed, and mandated pharmacy reimbursement. First is traditional or spread pricing. Some health payers may choose a traditional network where the PBM bears the risk that it can deliver a pharmacy network at or below the cost it has contracted with a client. And this is called traditional or spread pricing. Other payers may choose a pass-through network where the payer pays what the PBM pays the pharmacy for every dispensed prescription. Whatever the choice, we believe employers, unions, or government payers are in the best position to decide how to pay for drugs dispensed through their pharmacy network based on their unique circumstances and needs. Several states, however, have enacted legislation that prohibits traditional pricing arrangements between PBMs and clients, which therefore prevents payers from having a choice in how they contract with PBMs and forces them to accept pass-through pricing as the only way to pay for dispensed drugs. A second common theme in state legislation is laws restricting how pharmacy networks are designed. And these laws vary, but commonly prohibit payers from requiring the use of a specific pharmacy in order to obtain a drug or to receive a reduced copay or higher quantity limit of a drug. For example, this could be a requirement to use a mail order pharmacy rather than a retail pharmacy, or this could be a requirement to receive specialty drugs from a certain specialty pharmacy. Some legislation also applies to the practice called white bagging. White bagging is where a healthcare practitioner prescribes a medication to a patient, and the medication is shipped by a specialty pharmacy directly to the facility where it will be administered to that patient. And then the specialty pharmacy bills the health insurer directly for the medication. White bagging is a practice that saves payers money when compared to the provider practice of buying the drug and billing the insurer for the cost of that drug. Legislation aimed at white bagging typically restricts a plan from requiring physician-administered drugs to be dispensed by a particular pharmacy and shipped to the physician for administration. Lastly, an issue we saw emerge this year as a top trending issue as compared to prior years is mandated pharmacy reimbursement. With increasing frequency, states are considering legislation that would require PBMs to pay pharmacies a minimum reimbursement amount based on a cost benchmark, plus a mandated dispensing fee. For example, the legislation may require a minimum reimbursement amount based on a nationally published benchmark or on the pharmacy's actual acquisition cost, and a dispensing fee based on the state's Medicaid program dispensing fee, which is typically over $10 per prescription. This type of legislation removes any incentive for pharmacies to look for the lowest possible price from wholesalers, and mandating dispensing fees at amounts that are many times more than a payer's current dispensing fee will cause pharmacy benefit costs to skyrocket for that payer. So while most state legislatures have wrapped up their 2024 sessions, these three trends are ones that we expect to see again in the next year's state legislative sessions.
Before we go, Marissa, I'm hoping you can speak a little bit more on the advocacy efforts underway at Optum. Some of the work we do as an organization, as well as some of the work we do in partnership with others. As you describe that, I would also love if you could tell our listeners that if they have interest in supporting us in these efforts, how can they get involved?
Thanks. Great question, Scott. Our focus, as Sarah and I work, is focused on how we can continue to inform policymakers of potential positive and negative effects of legislation. Both federal and state policymakers want to find a way to lower drug costs. So our roles, working along with our advocacy partners, is to make sure they understand the impacts of this legislation they propose and to help provide concepts for the legislation that will achieve the policy goals to lower the cost of prescription drug benefits and maximize health outcomes. Sarah and I do this work in partnership with advocacy partners, both our trade associations and our enterprise external affairs team. Our message is simple. Employers, unions, and other health plans deserve to have meaningful choices in how they offer prescription drug benefits and manage the costs associated with those benefits. And while Optum Rx and our industry coalitions continually share the facts with policymakers, payers in the pharmacy benefit space can be the most influential voice, or are the most influential voice. Whether the topic's copays, rebates, reporting, pharmacy networks, it's the payers, along with their benefit consultants, that would be best at educating legislators that they need flexibility to manage benefits as they and their consultants determine to be the best for them and their members. So for anyone listening who's responsible for managing pharmacy benefits, you can share your expertise with federal and state policymakers, whether it's in meetings, letters, phone calls, whatever works best for you. If you are an Optum Rx client, please let your account management executive know that you want to work with us to protect your ability to manage your benefit as you know best.
Marissa and Sarah, this was incredibly informative today. Thank you for spending time with us. Thanks for listening to the Pharmacy Insights Podcast. I'm your host, Scott Traeger. Tune in again for more discussions as we examine the most important issues in pharmacy care services.